Imagine this scenario. You're in clinic, and a patient presents with really quite dramatic, visible destruction of their shoulder joint. Yet, surprisingly, they report minimal pain.
Hmm.
This perplexing clinical picture often signals a rare but absolutely critical diagnosis in orthopedics, Charcot arthropathy of the shoulder.
Indeed, it's one of those conditions that, well, it truly puts our diagnostic skills to the test, doesn't it?
It certainly does. Today, we're undertaking a deep dive into neuropathic arthropathy, or Charcot joint, specifically focusing on its rather intriguing manifestations in the shoulder.
Right.
Our mission is to unpack its complex presentation, the often hidden underlying neurological conditions, the crucial diagnostic journey, and the evolving treatment landscape for this challenging condition. This is really an essential conversation for any orthopedic professional.
Absolutely.
So let's begin by defining this enigma, understanding what Charcot arthropathy actually is.
What's truly fascinating here is that Charcot arthropathy, neuropathic arthropathy, is defined as an unusual, chronic, degenerative joint disease directly linked to decreased sensory innervation.
Okay.
The hallmark, as you rightly pointed out, is this profound paradox. You're observing significant joint instability and swelling, yet the patient frequently reports surprisingly little pain.
It's quite startling.
It is. Clinical observations even highlight that approximately 50% of these joints can, astonishingly, be painless.
That truly is striking a joint in such disarray, yet the fundamental pain signals just aren't getting through. Given this paradox, how often do we actually see these joint symptoms presenting before the more overt neurological signs?
That's a critical point.
And what does that mean for us as orthopedic surgeons in early detection?
Well, orthopedic surgeons are, in fact, often the first clinicians to encounter these patients, precisely because the joint symptoms can emerge earlier. It happens quite often.
Right.
This underscores the absolute necessity for a high index of suspicion, because we're on the front lines of what could be a hidden neurological condition.
It's a condition with quite a long history of recognition, too, isn't it?
Oh, yes.
I mean, from Musgrave's descriptions of swollen joints and paralyzed patients way back in the 18th century, to Mitchell's observations of bizarre joint changes and spinal cord paralysis in the 19th, right up to Jean-Marie Charcot himself, who gave us that incredibly detailed characterization of rapid joint deterioration in tabes dorsalis.
That historical context is vital, yes. It reminds us that clinicians have been grappling with this enigma for centuries.
So, while rare now, it's certainly not new.
Not at all. Now, when we consider its predominant causes in joint involvement, globally, diabetes is the most common cause of neuropathic arthropathy, typically affecting the foot and ankle.
That's what we commonly see, yes.
Exactly. However, for upper extremity involvement, and particularly the shoulder syringomyelia, is the primary underlying culprit.
Right, Syringomyelia.
It's found in roughly 6% of Charcot shoulder cases. And remarkably, around 80% of upper extremity neuropathic arthropathy is attributed to Syringomyelia.
80%? That's a huge number.
It is. That's a statistic that should immediately trigger a red flag for any of us in shoulder and elbow practice.
That's an absolutely critical figure for orthopedic professionals, indicating where our focus needs to be. So when we see a Charcot shoulder, our mind should immediately turn to a potential syrinx.
Precisely.
Are there other, perhaps less common conditions that can also be associated?
Yes, definitely. Other associated conditions include teves dorsalis, which is neurosyphilis, chronic alcoholism, leprosy, traumatic spinal cord injury, congenital pain insensitivity, multiple sclerosis,
Okay.
and even, somewhat ironically, intra-articular corticosteroid injections have been implicated.
Right. The how behind this dramatic joint destruction is really the core of the enigma, isn't it?
Yeah.
We have these two competing theories trying to explain it, the neurotraumatic and the neurovascular theories. Can you walk us through what each proposes?
Certainly. The neurotraumatic theory posits that the fundamental loss of peripheral sensation and proprioception leads to repeated, unnoticed microtrauma.
Yeah.
Mechanical stress progressively destroying the joint.
Okay, so it's wear and tear without the warning signals.
Essentially, yes.
Yeah.
And poor fine motor control, often a feature of these neurological conditions, further exacerbates unnatural pressure on the joint surfaces.
Makes sense. And the other theory?
Conversely, the neurovascular theory suggests something slightly different. It suggests that sensory deprivation disrupts normal neurovascular reflexes. This results in persistent hyperobia. So, increased blood flow and the activation of osteoclasts, the bone-resorbing cells.
So that leads to bone being actively broken down.
Exactly, which in turn leads to significant bone resorption.
So one theory points to mechanical stress from unnoticed injury, the other to a biological process of bone resorption driven by altered blood flow. But what's truly baffling, and perhaps the biggest sort of unsolved piece of this puzzle, is why a syrinx, which can affect both halves of the spinal cord, so often results in unilateral joint involvement. Only one side.
Exactly. That unilateral presentation is a critical anomaly that, frankly, neither theory fully explains yet.
What does that tell us about our current understanding? Or perhaps misunderstanding?
Well, it forces us to consider that perhaps there's a third, as yet unknown factor at play, or maybe a highly complex interplay that we haven't fully mapped out. It's a constant reminder of how much we still have to learn about this disease. And it underlines why maintaining a high index of suspicion, even in seemingly benign unilateral cases, is crucial. The underlying cause could be far more systemic than it appears.
That's a powerful insight. So if syringomyelia is the central neurological link for shoulder involvement, let's turn our attention there. Understanding this specific disorder more deeply, what exactly is syringomyelia?
Right. Syringomyelia is a chronic, progressive, and degenerative disorder of the spinal cord. It's characterized by the formation of a fluid-filled cavity, or syrinx, within the cord itself.
A cavity within the cord, and its impact.
Its impact is quite specific initially. The syrinx first damages the decussating fibers, the crossing fibers of the lateral spinothalamic tract. These are responsible for pain and temperature sensation.
Okay.
This leads to the classic dissociative anesthesia, where patients lose pain and temperature sensation. But quite remarkably, they retain tactile and proprioceptive senses. Touch and position sense remain intact, initially at least.
Fascinating. And as it progresses...
the syrinx can affect dorsal column fibers and anterior horn cells, leading to reflexia, muscle weakness, and atrophy, commonly noted in the intrinsic hand muscles.
And that's where we might see that characteristic cape-like distribution of sensory loss you sometimes hear about across the shoulders and arms.
Precisely. That distribution must be a critical diagnostic clue in the clinic.
Definitely. What are the common underlying causes of syringomyelia itself, then? Where does it come from?
Well, syringomyelia can arise from various etiologies. These include congenital abnormalities like obstruction of the foramen magnum, but also trauma, infection, degeneration, vascular issues, or even tumors.
A wide range.
Indeed. However, it has a very strong association with Chiari malformation type I, a really strong link.
Great, Chiari type I.
We know that syringomyelia develops in approximately 75 to 85% of patients with Chiari malformation type I.
That's a huge proportion, making Chiari malformation a key suspect whenever syringomyelia is found.
Absolutely.
But there's another, perhaps less commonly reported factor you mentioned that can also lead to syringomyelia. Basilar impression. How does that fit into the picture?
Ah, yes, basilar impression. It's crucial, though often overlooked. It's a congenital abnormality of the occipital bone and upper cervical spine. Essentially, it involves the abnormal prolapse, or pushing upwards of the vertebral column into the skull base. Its incidence is about 1% in the general population, so not incredibly rare.
And how does it relate to Chiari?
Well, whilst both Chiari malformation and basilar impression can lead to syringomyelia, they represent distinct pathological processes. It's important to differentiate.
I see.
We actually reviewed a clinical case recently that highlighted a previously unrecorded instance of Charcot shoulder caused by syringomyelia secondary to basilar impression. It really broadened our perspective.
A good reminder to consider the less common causes, too. So, given this sort of chameleon nature and the hidden neurological links we've discussed, the diagnostic pathway becomes our critical roadmap.
Absolutely.
Where do we even begin to unmask it for orthopedic surgeons in the clinic? What are the key red flags we should be looking for?
The clinical manifestations are varied, as we've said, but key signs include joint instability, swelling, and dysfunction.
Yeah.
And this may or may not have a history of trauma. On physical examination, you'll almost certainly find joint laxity, crepitus, maybe an effusion. It's also vital to look for decreased muscle strength in the upper extremity.
Okay.
And as we mentioned, that characteristic cape-like distribution of sensory and temperature changes across the patient's back and arms. Asymmetric or absent deep tendon rhizexes are also highly significant indicators.
It sounds like it can be quite a mimic, closely resembling other serious conditions. What about differential diagnosis, particularly when we're facing something that looks like an infection, which must happen?
Exactly. That's a major pitfall. Charcot joint can closely mimic infective processes, presenting as a swollen, warm, erythematous joint, It can even mimic tumors sometimes.
So what are the crucial steps there?
This necessitates a thorough exclusion process, often requiring immediate steps like, well, aseptic joint aspiration is key, and possibly biopsy. You have to definitively rule out infection or malignancy.
Those sound like absolute must-dos.
They're game changers in management. A misdiagnosis here can have severe consequences. You really don't want to miss an infection or a tumor.
That's a crucial practical point. This brings us directly to imaging. Where do we absolutely need to start, and what are we looking for on initial films?
Plain film radiographs. Always. They are the gold standard for initial diagnosis of the affected joint.
And what might we see?
Well, you might see anything from early degenerative changes, which could initially be mistaken for routine osteoarthritis.
Right, easy to miss early on.
Very easy, all the way to late-stage severe joint destruction. This includes things like supraremedial flattening of the humeral head, glenoid sclerosis, extensive bone resorption, periarticular soft tissue calcifications, and eventually joint subluxation or even frank dislocation, the whole spectrum of destruction.
Quite dramatic changes then. And beyond plain films, what other imaging is absolutely critical, especially to confirm that underlying neurological link?
A cervical spine MRI. That is absolutely critical to rule out the presence of a syrinx when you suspect neuropathic shoulder arthropathy.
And what does the syrinx look like on MRI?
The syrinx typically appears with signal intensity equal to or higher than CSF on T1 weighted images. It's usually quite apparent once you look for it.
Okay. What about CT scans? Do they have a role?
Yes, a CT scan can also be useful, particularly if there's significant concern for osteomyelitis or chronic infection. It's better for looking at bone detail, things like intraosseous gas, cortical destruction, and sequestra.
Right, for ruling out infection again.
Exactly. And for distinguishing between Charcot and infection specifically, nuclear medicine scans can be particularly helpful too.
Ah, you're talking about the white cell scans.
Precisely. The indium-labeled white blood cell scan. It's a vital tool. While a standard technetium bone scan can be hot for both neuropathic joints and osteomyelitis.
Right, not specific enough.
Correct. But an indium WBC scan will typically be cold or negative for Charcot joint disease, but hot or positive for osteomyelitis. This provides a crucial distinction.
That's incredibly useful.
It helps us avoid misdiagnosis and inappropriate management, which is paramount in these complex cases.
That's a vital takeaway for any clinician dealing with suspicious joint pathology. So once we have a clear picture, hopefully, what are the core treatment philosophies and strategies for Charcot shoulder? What are we aiming for?
The primary goals in managing neuropathic arthropathy are, well, they're straightforward in principle, but challenging in practice. Early diagnosis is key. Then, treating the underlying offending agent or agents, usually the neurological cause, to halt disease progression.
Right. Stop it getting worse.
Exactly. And meticulous maintenance of joint and extremity function, preserving what function is left.
And what about non-operative management? Is that a viable first line, or are we always heading towards some kind of intervention?
No, conservative measures are definitely the first line. These include the basics. Rest, using nonsteroidal anti-inflammatory drugs to reduce synovial inflammation, protected immobilization with a sling, and activity restriction, modifying what the patient does.
And how successful is that?
Reports indicate that approximately 50% of patients actually show some improvement with non-operative approaches alone.
That's encouraging for a subset of patients. What about injections?
Well, for symptomatic pain relief, intra-articular corticosteroid injections can be used. Some reports show temporary but significant pain reduction, but obviously you have to weigh that against the potential theoretical risks we mentioned earlier.
Of course. But that's good to know for managing symptoms. What about addressing the underlying neurological issue? That seems critical. When does neurosurgical intervention come into play, and how impactful is it?
Referral to neurosurgery for syrinx evaluation is a paramount early step. It really should be a top priority as soon as you suspect it.
Okay.
Now, posterior fossa decompression, specifically for Syringomyelia linked to Chiari, has been shown to effectively slow disease progression, maximize joint function, and even lead to improved bone quality.
Improved bone quality, really?
Yes, some compelling case reports even detail glenoid fossa regrowth following successful decompression. It's quite remarkable. And clinical data, looking back at patients, suggests real benefits. A review of 19 patients undergoing neurosurgical decompression showed that 15 of them had neurological improvement without further joint deterioration.
15 out of 19 is significant.
It really underscores the profound benefits of early neurosurgical intervention. And of course, other neurosurgical techniques like craniotomy, maybe a syringoperitoneal shunt or laminectomy might also be employed, depending on the syringe's specific underlying cause.
That really highlights the absolute necessity of a truly multidisciplinary approach here. Neurosurgeons and orthopods working together.
Couldn't agree more. It's essential.
What about orthopedic surgical interventions then? Historically, I know total replacement arthroplasty for Charcot joints has had pretty disappointing outcomes. How has that evolved?
That's correct. Arthroplasty has traditionally yielded disappointing outcomes. High risks of recurrence, infection, loosening. This is why neuropathic arthropathy has been a strict contraindication for most FDA-approved shoulder prostheses, largely due to those concerns about prosthetic loosening and ultimate failure. The bone quality is often poor, the stability isn't there.
So what does this mean for our surgical approach today? Has anything changed? Are there emerging options, perhaps with different patient selection criteria?
Yes, the literature is definitely evolving on this. While historically challenging, arthroplasty, when considered perhaps as an off-label use and crucially following successful management and stabilization of the underlying neurological condition.
That seems key.
It is key. Under those circumstances, it can now be considered a viable option. Some studies indicate up to 70% improved function at 5 years with procedures like hemiarthroplasty or, more commonly now, reverse total shoulder arthroplasty.
Reverse seems logical given the potential cuff issues as well.
Exactly. It provides inherent stability. But for severe pain unresponsive to conservative measures, shoulder arthrodesis fusion remains a solid alternative.
Fusing the joint.
Yes, aiming for a functional fusion position. Typically around 20 to 30 degrees of abduction, forward flexion, and internal rotation to facilitate essential daily activities like feeding oneself.
Okay, so arthroplasty is maybe an option now, carefully selected, and fusion is still a reliable fallback.
That sums it up well.
And what are the potential pitfalls, the complications we need to be particularly mindful of with these surgical interventions, especially given the underlying neurological compromise?
Well, infection remains a significant risk, perhaps higher than standard arthroplasty, particularly if the underlying neurological condition isn't adequately managed and stabilized first.
Right. Infection control is paramount.
Absolutely. There's also the risk of upper extremity, deep vein thrombosis, DVTs, and specifically with reverse total shoulder arthroplasty, acromial stress fractures have been observed and are a known complication to watch for.
Okay, so definitely not without risks. This has been a fascinating deep dive. Charcot shoulder, while rare, is clearly a complex condition demanding a high index of suspicion and, as you've stressed, a truly multidisciplinary approach.
Recognizing its varied presentations and understanding the critical role of neurosurgical intervention for underlying syringomyelia seem absolutely paramount to improving patient outcomes.
Agreed.
It's a powerful reminder that orthopedic pathology can often be the first sign of a deeper neurological issue we need to uncover.
It absolutely is. A challenge and, as you say, a call to vigilance for all of us.
So, perhaps a final thought for our listeners. As orthopedic professionals, given the often insidious onset and profound joint destruction associated with Charcot arthropathy, how might we proactively integrate more targeted neurological screening and imaging into routine assessments, particularly for unusual shoulder presentations, to facilitate earlier diagnosis and intervention?
A truly critical question for future clinical pathways, I think. How do we build that suspicion into our workflow earlier?
Something for us all to consider as we evolve our practice. If you found this deep dive valuable, please do consider rating and sharing the show with your colleagues.
Indeed.
Join us next time for another deep dive on Deep Dive Ortho.